Hi, good morning. Dave Michelson from Loma Linda University in Southern California. Dr. Parsons, since you brought up this, I'm going to vocalize a couple of the questions I put in the chat. So, working in an institution with a lot of families that might come from very far away, have you set up any working relationships with the hospital or with any support organizations to house families near your hospital?
We have. We typically would use Ronald McDonald House or relatives or friends. I mean, in the trials, the pharma companies would support patients staying, but we have to organize that through the hospital, and yes, we have worked on that.
And then my second question was because you analogized this kind of gene therapy as like solid organ transplant. And in that context, we actually, decide whether a family is appropriate for transplant outside of the child's characteristics. Like they have to be reliable about coming to the laboratory or to follow-up visits and giving their children, anti-rejection medications. Have you and your institution thought at all about how you will be screening families for appropriateness for gene therapy?
So that's a great discussion and something that we have brought our ethics group in as well to discuss. What we did set up was a memo of understanding at the very beginning. And so for any of the therapies, including nusinersen, it started with that, not just the gene transfer therapies, is that all children, in my belief, should have access. This should be shared decision-making, but part of the shared decision-making for what choice a family selects for therapy involves sitting down and saying, realistically, what can you do? And so we do actually have an instrument, documented memo of understanding, where we say to the patient and the family, this is what we will provide to you, this is what we expect for you to provide to us, which includes coming in. They have the schedule as soon as we know what we're going to do. They have the schedule for laboratory assessments. I mean, if they live far away and in the mountains, if it's just a lab, we can work with the primary care providers, and that's what I mean about having good communication and networking as well. But we really have to see the patients, and certainly in the at-risk period for gene transfer therapy, we really want to have them be with us so we can see them and lay our eyes on them. But we lay all of that out beforehand, and then they do have to respond to that memo of understanding to say, we agree that we will do this, just as you would with a trach or a transplant, to say this is a serious therapy. It's not just an IV and you get to go home. And so to me, that has been really helpful and it's worked well for us.
Thank you.
Thank you.
I could maybe just add a couple things on that same subject, because we've faced this with a couple of our DMD patients who are at the age of the approved drug, who I can't even get to clinic for a visit maybe once a year. And we've really struggled with how do we, and transplant has a whole system established for this, right? And we don't have any system other than, I know this family, I know some of the struggles they're having, and I don't have a way to help them with some of those struggles. There's just no infrastructure at Colorado. If you have better infrastructure, I can put them in Ronald McDonald House for a few weeks. I can do that. And and in your question, I think you asked about that. We've had good luck with that with our Ronald McDonald House. But I think there are some issues we have to face as a community as we build these programs about equity and how do we deliver these drugs to families who, struggle. And sometimes those aren't the families that live far away from me. Sometimes those families are the easiest ones to work with. It's the one who lives, or maybe doesn't even have a home. They're living in their car. And how do I get that person here for clinic visits once a week and labs anytime I need them and communicate? And I don't dare to give a gene therapy to someone in that space. It's too dangerous. And I don't know how to help fix that problem either. We don't have that infrastructure.
Okay, so if there's no more questions in the audience, I'm going to go with the ones that we have online. So the first one here is, should patients be treated prophylactically with eculizumab?
Okay, so I think that this is a health economics question. Would it prevent the occurrence of TMA in this patient population? I would assume so. I think it would. Is it a frequent enough complication that it's cost effective to give eculizumab to every single patient? I'm not sure what the answer of that is. It's possible, since we know that the time frame for the onset of TMA is in the first 2 weeks. So you probably could get away with giving a single dose. But beyond that, I can't make a firm recommendation either way.
Right, and it's not without risk, right? Eculizumab has risk for meningitis that's not low, so you have to be aware of that risk, right?
Correct. There's a risk. The risk is compounded by the length of therapy. So if you're only giving one dose, I think that the risk is relatively low. And then that risk can be obviated by the administration of antibiotics. But now we're getting into giving a therapy to combat the therapy you just gave. I don't know where this ends, but
Right. I think that reiterates the need of having multidisciplinary teams who know these drugs, understand these drugs, and can help with the next problem we bring up because we gave them.
yeah. I would just say I don't think it's unreasonable. It's not an unreasonable thought.
Yeah, and just a comment that there's one of the new gene therapy clinical trials that are incorporating this, so we will also see whether in that cohort of patients we are seeing less side effects associated to that. Okay, moving gears to other questions. Some SMA patients don't respond to multiple treatments given very early. How do we clarify if these are treatment failures or uniquely severe patients?
I could talk. I could start. I think this gets to the idea of what does it mean to be pre-symptomatic. I think there's a lot of data in the post-marketing registries, and some patients do very well. Like some of my patients, they look pretty normal. It's a 2-copy kid running around at 5 years old in kindergarten doing all the normal things, and others aren't as well. And the ones we've seen that didn't do as well, we have seen in several patients that their onset is just earlier, and even in the 2 weeks kind of time frame, they have progression of their SMA. And so I don't know if the data we have really answers the question, are those patients who aren't doing well, not doing well because of their SMA was already moving really fast when we started treatment, or if the therapy failed. I don't think we can differentiate that. I do think there's variability in response, and we don't have a good way to classify it. One of the things then, and Leslie talked about Melissa McIntyre's study with the sensors in the babies. One of our interests, because I'm working with Dr. McIntyre on that, but one of our interests there is really how do we identify symptoms in a baby who doesn't do very much, at baseline. And can we see that in those signals on the thing so that we can at least see it and measure something?
Yeah, and I think that there are a couple things. One is all of us who've taken care of the newborns now that we have newborn screening, we see the babies, we have to get authorization to be able to treat them. All of us have seen babies get weak. I mean, where you see them, day one, we see them within 24 hours of identification on newborn screen, where they're okay. And then within, 2 or 3 days when we're going to give them treatment, now suddenly they have a head lag and they're weak. I mean, it can progress really quickly. Something that we have done is actually just to look at electricals and do baseline EMGs. So in a lot of the trials, the kids, had to have CMAPs that were 1 or 1.5. We do those at baseline, and we know that the kids that are under 1, they're not going to do as well. I mean, their outcomes may be okay, but they're just not going to be quite as robust. So it helps us to maybe look at realistic expectations. And if a kid has a CMAP of 2, if they're a 2-copy kid, you kind of go, okay, they're probably going to respond a little bit better. We really still need the biomarkers. That's going to be the bottom line. But I don't know if you have ideas, Leslie, for something that you would look at.
Yeah, no, I think you both have touched on that. I mentioned it a bit in my talk, is I wonder if those sensors will be predictors in that same kind of biomarker sense. But I agree. I feel like the challenge, and I feel like that's not to open this can, but I do think that's where kind of the combination therapies, where people are potentially starting, babies on risdiplam as they're waiting for to see whether or not that the titers are present to do gene therapy, or whether it's approval, even waiting on insurance approval, payer approval those are the things that I think can sometimes complicate that progression that we may not think is there, but it's happening before we can get them dosed.
Right, and even in days matter in
Yeah.
those measurements. And we had a case early in the year where, we did an EMG 5 days before treatment, but that patient in those next 5 days dropped. And then I didn't get an EMG on the day that we did the gene therapy, but then they improve again. So we're really fighting against a time scale we're not used to, right? And when did we make the measurement?
Which fortunately is different in DMD,
Yeah.
right? So you have a little more breathing time to be able to say, okay.
And that actually really changes the dynamic of how we think about gene therapy for DMD, right? To take the pressure off the urgency, that we can take our time on think about all of these issues around safety a little more.
And this is the perfect segue to the next questions. One, with these patients, if DMD is also approved in newborn screening, should we treat them early? And two, is NSAA, these are two different questions, but in DMD, is NSAA the best measure in our patients who are following them in clinic, those kids with Duchenne that has been treated with gene therapy?
Let Leslie answer first.
You answer about that.
So to answer the question about the NSAA, and I'm assuming that means with the 4 to 5 year olds, that is what the question is, and not talking about if we were to enforce or to start newborn screens. And the North Star we have really great natural history data to know that the developmental maturity that occurs within a child as they're gaining age to about the age of 7, there are items on the North Star that are not developmentally really appropriate. Stepping up a step for a 3-year-old is difficult, regardless of whether you have Duchenne or not. And so it really is kind of a difficult question to answer when you start to think about the younger age and what is the most appropriate, because you have to look at them in the sense of developmental delay in a sense of normal development, but also in relation to natural history of Duchenne. And I think you all know, too, that we all see differences in onset of symptoms in those weaker boys that are showing symptoms much earlier. I think the North Star can give us some information of just how they look in relation to other boys with Duchenne. But then that complicates looking at norm referenced or criterion reference scales, too, just because of the progression of the disease. So I don't know if I have an answer of whether I think it's the best thing we have for the disease specific, kind of to look at motor function in that sense.
I think one difficulty with a lot of the motor function assessments is actually not the tool itself, but the way we apply the tool.
Yeah.
And they're really tools designed for clinical trials
Yeah.
to look at a cohort.
Can I interrupt? Because
Yeah.
as I'm thinking through, I think the thing I like about the North Star are the time function tests. I think the time function tests are probably the most clinically meaningful for us and probably the best predictors for the boys as well. We have an idea of kind of, so that's where I would say the NSA, it kind of fills that space, is the fact that it does have the time function test as part of this scale.
Yeah, and I think we'll continue to use it either way.
Yeah, I do too.
But I think, how do we apply it to an individual who's standing in front of you as opposed to a cohort in a clinical trial where we can measure differences in a very different way? So I think, and that's generally true for all the disease we take care of. Like, we have these tools that are clinical trial tools, and now even insurance companies say you have to use them to follow outcomes, and they're really not designed for that purpose, right? And there's so much we don't know.
They're
on
not
that.
always appropriate.
Yeah. I can talk about newborn screening or.
Go ahead.
So newborn screening is really important, I think, for the whole community. Just to say, I think there's 2 states that aren't screening for SMA now. Nevada is one of them, and they start next week. So we're getting close to every state and every baby born in the United States screened. Newborn screening is an important initiative, I think, and PPMD is here, and they've been pushing that as well. I think multiple states now have processes in motion to start newborn screening for Duchenne. But I think it's a very different scenario from what we're doing with SMA and infrastructure built around SMA that is a baby's born and I hear about it on the 5th day of life and I see that baby on the 6th day of life and I try to treat them within a week. There's this very intense time pressure that we won't have with Duchenne. And And a couple things that we don't know on gene therapy for Duchenne is, when is the right time to transduce muscle? One problem we don't have in SMA is that neurons are non-dividing cell for the most part. You know, if we transduce the neurons of a newborn, they're going to have the same number of newborns on the 1 week of life that they have at 3 weeks of life at 10 years of life. But in muscle, that's not true. So you're actually making more muscle cells. And is there a dilution effect? So if I treat too early, do I transduce a bunch of muscle but then make a lot of new muscle that doesn't have the transgene? And where is the exact right timeline? Because it stands to reason that it's the right thing to treat early, right? That I don't think anyone questions that. But where do we do it? And we don't have the time pressure of clinical symptoms. So that's the thing we need to figure out. And I think the other thing we need to figure out has to do with the measures. How will we know it's working, and how will we track progress in let's say we give gene therapy at 6 months old or a year? How do I track efficacy in that patient? And if I follow them for 10 years, I'm going to know how it worked out. But we don't usually have that luxury, right? We want to kind of know in the first year. And we need to develop those tools, which I don't think we have.
I think we also need to develop, if we end up with newborn screening, how do we mitigate the pain and agony of a diagnosis without doing anything for a year or two?
Right.
And what can we do? Like, I mean, one of the big, to me, unmet issues in Duchenne is the cognitive and neurocognitive issues that we see. And I am not necessarily optimistic that the gene transfer therapy is really going to particularly address those issues, but those are issues that we can see in infants and that we actually can help treat with, going back to the idea of multidisciplinary care. It's not just going to be a treatment and everything's fine. We really have to look at the whole patient, and arguably, the neurocognitive effects can be extremely limiting. So during that first 2 years or 3 years, whenever we, would end up getting approval or authorization for treatment, how would we assess patients? How would we help the family during that period of time to help support the baby and maybe help them from a developmental standpoint, which is a quality of life issue that is huge.
Okay, we have time for one more question, but I wanted to say that as we do every year, we will answer all the questions and then get back to you. So I'm gonna go to one of the questions related to the use of steroids. So the question is, what do you tell patients about the value of risk of high-dose weekend dosing versus daily dose of steroids? Do you have any insights on lower dose of weekend dosing? Do you think vamorolone could be effectively administered on weekend dosing?
Do you know the answer?
I would love to hear your answer. I don't know.
Who knows the answer to those
Yeah,
questions?
who knows? Yeah.
These are really good questions that I don't think we know the answers to. I didn't present data just for time limitations on the weekend dosing. There's good data on efficacy for weekend dosing in prednisone. I don't know that I've seen data just because I don't read every paper on deflazacort, or certainly there's no data I'm aware of on vamorolone. Stands to reason that they could work in similar ways. There is some biology behind that the way our bodies sort of respond to corticosteroids in our sort of own physiology is that there's a pulsatile nature to corticosteroids in our normal physiology, and there's some thinking around the weekend dosing that sort of being on that intermittent dosing can take advantage of some of those normal cycles that we have. I don't know that data very well, but it's a thing.
Hi, can I just comment on that? I'm Tanya Tavasalo. We're actually doing a study right now on daily dosing, twice weekly dosing of prednisone using the daily dose. So it's a low
Right.
dose. And it's based on the Matteo Quattrocelli paper, exactly with the idea of the transient kind of, giving the muscle just that transient dose. It's been very challenging to find steroid-naive children, but we have 15, I think, boys right now in our trial, and we have data on, I think, 8 or 9 of them.
What
that
ages are your boys?
They are between age of 4 and 8. So
Nice.
we'll be hopefully publishing some of that data soon.
Right, that sounds like a really
Yeah.
important study.
Yeah, but it's really interesting because they're definitely growing in the same rate, and yeah, so we can talk more later.
Sure, sure. These are all studies that we need to do, and I think the data around steroids kind of gets pushed to the side. It's just the thing we do, and so we don't always get to the weeds.
Yeah, and there's more because, in our experience for those patients that had received gene therapy, many of the parents are coming to us say, well, okay, can we stop the steroids now? And that is another question that we don't have the good answers. I believe that we might end up with a smaller dose of what we are using right now, but we need the data. So I hope that we can put that in perspective. So with that said, thank you so much for your attention